Hello, everybody. Welcome to MHTV. We're really pleased to welcome you today for a really good session. Some very interesting and exciting guests today talking about addictions. But before we do that, obviously, I'm Nicky Lambert. I will just hand you over to my colleague, Vanessa, who's going to tell you a bit about how you can join in.
Hello, everybody. Welcome tonight. As Nicky says, we've got really interesting evening, hopefully. I'm going to be doing the social media tonight. So you can join in two ways. You can either join in on Twitter by following MHTV and tweeting us to the hashtag there, and we will bring any questions into the session. Or you can go on Facebook Live. In fact, you can do both if you want to. To join on Facebook Live, you just need to like the Unite MHNA page and you'll see the live feed there. If you want to comment or ask any questions, there is an opportunity on Facebook to do that. So I'll be concentrating on that, and hopefully as well, I'll be sharing any links and resources tonight that you might find useful. I'll share them on Facebook and I'll share them on Twitter.
Okay, so what I'll do now is I'll just introduce our guests and then we'll come back to Vanessa for a word on International Suicide Day, which it is today, Suicide Prevention Day, obviously. So first, obviously, to Carmel. Carmel, can you introduce yourself?
I can. Thank you, Nicky. Thank you, Vanessa. Thank you, Dave. So I'm delighted to be able to join you this evening. My name is Carmel Clancy. I am a nurse, I suppose, first and foremost, both general and mental health trained. I'm an addiction nurse. I would always identify or self-identify as. But my actual proper day job, for want of a better word, is I'm head of school for the School of Health and Education based at Middlesex University, which is in Hendon in North London. I'm also a professor there in addictions and mental health, and looking forward to this conversation.
Absolutely. And Adrian?
Hi, I'm Adrian Jugdoyal. I'm also at Middlesex University, and I have a strong specialist interest in drugs and alcohol. However, like Carmel, I'm dual qualified, and I've always had drugs and alcohol as a passion within addictions, but also in physical health. So when I worked in A&E, I often was drawn towards the alcohol and drug-related presentations. When I was in drugs and alcohol, I was often delving towards hepatitis type stuff. So I've always had alcohol and drugs as part of my professional career.
Thank you very much. All right, so just back to Vanessa briefly.
Yeah, we just wanted to really say a few words because we're aware that it's World Suicide Prevention Day, and we were just saying before we went live actually that it's crept up on us a little bit this year with COVID and everything, but it feels important that we should acknowledge it. If you follow the hashtag on Twitter on World Suicide Prevention Day, you'll see that there's lots of tweets and lots of people sharing the stories. So certainly, from that point of view, it's a great initiative for people talking and sharing the lived experiences. I would also say, really, one of the things for me about suicide prevention is that it isn't just about people who work in mental health. It's about everybody. Everybody's got a collective responsibility where suicide prevention is concerned, whether it's, working at a train station, working in a college or university. And the message for me really is about, just reaching out to people. If you think that, you're working with a colleague or a friend and, you've noticed a change in them, or, they're going through a difficult time, like we all go through difficult times in our lives, reach out to somebody, have a conversation with them. The other thing I wanted to get across really quickly was that we know that there's a really disproportionate number of nurses who are taking their own lives. And as a nurse, I feel that's really important to highlight. Before COVID, I was starting to doing some work with Zero Suicide Alliance, which I would also look up because they offer lots of free training and resources around suicide prevention. But also to say that, we've been having conversations really about organising something through social media around nurses and raising awareness. And I know that Unite are really involved with some work that NHS England are doing. So there is work going on behind the scenes to look at nurses as a group, which is really heartening to hear, given, the lack of emphasis of it in the past and, some of the difficulties nurses experience. And I guess, for me, knowing the pressure that the healthcare workforce have been under during COVID, I think it's particularly important, isn't it, to highlight it at the moment. So I won't say any more because I don't want to, eat into too much of tonight's discussion. But just to say, if you're listening and, you're feeling low, reach out to somebody, have a conversation with somebody that you trust. If anybody wants to get in touch afterwards, happy to direct people to resources and sources of support as well, and organisations. So that's it really. Take care from me. Nicky, any thoughts from yourself before we start?
No, not for me today. Thank you.
All right. Thank you.
If Carmel and Adrian want to add anything, obviously when I come to you, please do. But just getting us started on tonight's main topic. The international perspective, Carmel, was something I really wanted to talk to you about, because you are involved in an institution called IntNSA. Could you tell us a little bit about that?
Yes, of course. So basically I'm currently president-elect, and I take over the presidency of this society in October. Mm-hmm. So IntNSA is called the International Nurses Society on Addictions. And it is primarily actually comes out of the US, because that's where it was sort of given birth to, I suppose, although it does have an international tag. And increasing over the last probably 5-6 years, there's been a real surge to try and expand the international footprint of that organization. And we have, give or take, around 9-10 different countries now engaged, including places like Nigeria, Tanzania, many European countries, Chile, where else? Brazil. And of course, as I say, the largest number of the members at the moment reside in the USA. It's been around initially as a national organization in the States in the sort of 70s, a little bit like IntNSA, people who remember IntNSA, Association of Nurses and Substance Abuse in the UK, a similar sort of time frame. But it merged in 2000 into the international. And so it is a dedicated society for nurses, not addiction nurses as such. You don't have to be an addictions nurse to join, but any nurse. And we would actually have a strapline that says that every nurse is an addictions nurse. And maybe we'll explain that a little bit more as we get into the conversation this evening. But ultimately, it's a great source of support. It's a membership organization where you'll meet like-minded people. If you're struggling still to find your tribe, so to speak, and you're interested in this field, I certainly recommend that you check us out. And the website, I think, is being tweeted very nicely by Vanessa. And we will get back to this again, but we're having a free month-long conference starting from the 4th of October, where we have over 60 different webinars, synchronous and asynchronous educational events, not just around nursing issues, all issues related to addiction. And we'd love to capture you and see you online there. So I'll stop at that, but it's a great source and point for nurses to come together.
Absolutely. And we'll be sharing links to, if we haven't already, we're sharing links to that conference as well. And if you've an interest, bear in mind, it's free, it's online, you can certainly access it and find something, I think, that will feed your interest. Yeah. Another thing I think that, Carmel, you've been speaking on a lot is this idea about upskilling the workforce. Can you tell me a little bit about what you mean by that?
Yeah, I mean, this goes to, I suppose, the wider issue and just what I've just said, that every nurse is an addictions nurse. If you think about, and it might be just for those who, if addiction perhaps or drug substance use is new as a subject area, or you haven't given it much thought, I thought it might be interesting for people to know, and I think that this is kind of quite dramatic, but drug use is directly or indirectly responsible for, quote, almost 12 million deaths each year. And that's phenomenal. In actual fact, if you think about it, that's more than the number of deaths from cancers. So while we often think of cancer as this sort of really concerning issue, sometimes addiction is a very invisible or hidden problem, often probably because of stigma, and we might touch on that later. But certainly it doesn't necessarily get, probably, I think, the attention it really deserves. And we're talking about, sort of suicide prevention, for instance, today. Over 350,000 people die from overdoses. And often, the overdose may be unintentional, but having worked previously in the drug-related deaths, I was part of that down at St. George's Medical School some years back. When you talk to the coroners, even though it might be described as an overdose, potentially unintentional, actually at the point that somebody is putting something into their arm and injecting, who knows actually what the thought process was at that point? And often we are missing intentionally, unfortunately, people who are at a very, very vulnerable point of their lives. And they actually just say, do you know what? I don't really care anymore. So there is a lot of hidden concerns within the drugs and alcohol field that often doesn't kind of get picked up in a way that it seriously needs to. And the reason I talk about upskilling nurses is that nurses, you know, whether we like it or not, nurses are actually in the trenches, in the forefront. You know, you're going to meet a nurse either in a school setting, you're going to meet a nurse in a primary setting with the GP, you're going to meet a nurse in an A&E setting, you're going to meet a nurse in a theatre setting. You know, you will meet a nurse everywhere. You'll meet them in your home, you'll meet them on the street, in outreach, you'll meet them, etc. So for me, if we could upskill and make drug and alcohol a core capability, a core skill, immediately you have now got a massive workforce who can at least start to deal with some of what I would call earlier steps. I'm not saying everybody has to be an expert or advanced practitioner. You do need the experts to take on the more complex and co-occurring issues in mental health and addictions. But early stuff, you know, that tip of the iceberg stuff, asking basic questions. What are you smoking? What are you drinking? Could you think about that? These are basic public health messages and interventions that I think every nurse should have in their toolkit. So there is a need to upskill everybody to feel comfortable to have these conversations. And I always say when I'm training people, you know, nurses kind of in some respects sometimes don't kind of cover the sex, drugs and rock and roll bits. And we do need to ask questions about this. We need to ask people about their sexual health. We need to ask people about their drugs and alcohol. And we certainly need to understand what people's recreational habits are, because they can veer towards poor choices. And nurses are on the forefront of having those conversations. So I'll get off my soapbox.
No, I think that's really helpful, and especially understanding what skills exactly are missing. And it seems to me they're questioning skills, which all nurses should really have.
Correct. Very, very basic skills. I mean, if you think about, you know, any question, you go into your GPs now, they tend to ask you basic questions. Are you smoking? Are you drinking? You know, what are you drinking? You know, kind of getting a measure of baseline around there. So these really should be questions that every nurse feels comfortable to ask. And unfortunately, our educational system, and somebody who's been working in the educational field for many years, feels slightly shy to say that we're not still good at that. And there are major gaps still, I would suggest, in our core curriculum, not just in nursing, actually, but in medicine, social work, right across all the professions. We have yet to get, it's almost like the horse is bolted, you know, and we're now talking about it because often most of the addiction courses are at postgrad level. What we need to do is we need to get them embedded into our core undergraduate level. And that means that, you know, I always use the argument that if you're a nurse, for instance, and this is a classic example, and you're not taught how to do a blood pressure in your nurse training, and you then go out onto the ward or you go into your nurse career, and the first thing you're asked to do is take a blood pressure. If nobody's shown you how to do that, you will then naturally, rightly assume that's not my job. So if we do not teach our student nurses, student doctors, student social workers et al. How to ask these questions, why would they not think that this is their job? Because nobody's trained them in it. So we have really a serious accountability as educationalists to get that right to start with and make sure that we actually allow people to go out fully prepared and ready to engage in what is a very complex world out there. And quite rightly, there is not going to be, and anybody tells me that they will never come across drugs and alcohol in their nursing, medical or social work career, you know, there's something wrong.
Yeah, definitely.
Living on an island in a Buddhist monastery, I think.
Okay. One of the things you did touch on as well was stigma. And I know that's something that Adrian particularly wanted to tell us about. Could you expand on that, Adrian?
So I know Carmel's done a lot of the background with regards to how alcohol is out there, drugs is out there, and often we turn a blind eye to it. And that could be due to society, it could be due to our professional, almost snobbery sometimes. So you've always got nurses who want to work in ITU or they want to work in CMHT. But when it comes to drug and alcohol, we've often seen it as this Cinderella service, which historically has been underfunded. The nurses don't tend to go there. They'd rather go somewhere else. But it's one of these jobs that when you go into it, you really enjoy it and you never really leave it. So the stigma is really odd. So if I was to say something like, 85% of the population of the UK drink alcohol. But then you were to look at nursing notes or medical notes and realise that history taking, drugs and alcohol aren't even brought into the social history, which tells me that either the doctor didn't think it was important, the doctor may have been embarrassed, or nurse, and there's something wrong there because it's not an intrusive question. I can think about times where I worked in A&E and there'll be a young lady coming into hospital with abdominal pains. So you'd ask all the general questions, what have you eaten? What's your bowel habit? Have you been for a week? I'd also ask sexual history because it will be relevant. And so certain conditions which are relevant aren't being asked those questions. So there's a report that came out about 5 years ago from NCPOD, National Confidential Inquiry for the Prevention of Death. And one of the key headlines that came out from that was, of patients who had a underlying diagnosis of alcohol-related liver disease, when they looked at their last admission to hospital when they died and retrospectively went through the notes, the question of alcohol wasn't even mentioned. So in their diagnosis, it said alcohol-related liver disease, but the clerking doctor or the nurses never asked that question. Now, I would ask you the same question if I had presented in hospital with COPD. I guarantee everyone would have asked me about smoking. Or if I wasn't smoking, when did I stop smoking? And if I was smoking, how much? They'd even offer me nicotine replacement patches and stuff. But for alcohol, no. And then what you tend to find is if you're not looking for it or you haven't questioned it, you'll tend to find that the teams late at night or early morning presented with let's say a 50-year-old man who's come in with a fractured ankle falling off their bike or at the rugby in acute withdrawal. And for me, that brings its own risk, because if we weren't hiding around this alcohol problem or not willing to look at it, this presentation of alcohol-related withdrawal or seizures, etc., wouldn't have happened. So there is a lot of stigma around it. And I don't know whether that comes across that those who drink are bad, or is it because it's got this double-edged sword? Because the media do push it out that if you can't have a good time unless you're drinking. Up until recently, a lot of our sporting events were sponsored by alcohol and even cigarettes. Some of us are old enough to know when the snooker was sponsored by Rothmans or on all these other things. But nowadays, it's its responsibility. But again, I think healthcare might not be looking at it in that same way. There's been a lot of work, especially in acute medicine and acute admission units, where the government has put money using sequins to increase alcohol-related screening into hospitals and GP surgeries, etc. And for me,
can you just explain sequins for anyone who thinks it's sequins?
Sequin is it's a quality improvement initiative where central government or even local government would give money for an intervention, and the intervention is to have a positive gain on certain groups of individuals or society as a whole. So there was a sequin about 4 years ago that basically pushed that every A&E department must have screening questions for alcohol-related presentations. Now, I'm not going to go over what alcohol can affect you in physical health or in mental health, but the problem is there. And I would say, why are they paying us to do a job that we should have been doing anyway? The question should be there very much front of house all the time. But what you found was that doctors wouldn't ask the question, or they only asked the question to the drunk person.
Okay. So are you saying that because alcohol is all around us as part of society, it's like invisible? Or are you saying that people are embarrassed?
I think a bit of both. I think invisibility could be because I drink, I can look after myself, you're the one with the problem. Or if I had a drink and I fell through, let's say I fractured my ankle again as an example, I can rationalise that for myself. But when it comes to someone else, you're not willing to listen to why this happened. Can be quite judgmental sometimes with regards to alcohol and drugs. And yes, earlier on before we came online, we spoke about sex, drugs and rock and roll, which has been common in the 50s, 60s, 70s, 80s, all the way through. We know about the 27 Club of all these rock stars who've passed away of natural causes, but generally alcohol or drugs. So it's not a new phenomenon. So I don't know whether it's because we are embarrassed or we're willing to blame ill health or misadventure on you, but we're equally likely to do it ourselves.
I think, I think that there's a lot to be said for that. I think sometimes health professionals who are prone, we have to say, to stress-related smoking, drinking, poor food choices, so basically surviving all day on Kit Kats out of the machines to get by and feel better about things, can be very judgmental to other people about how they cope with difficulty and distress.
Well, just to add one quick bit to this, all of us probably here are aware that when we did our nurse training, there was a social club attached to the hospital.
Oh God, yeah.
And
hold my hands up to the social club from back in the day.
You're making me now reflect back, because I can remember, and those of you who can remember when you were allowed to smoke on the wards. And in actual fact, I mean, I'm an ex-smoker, so I do know that, many of the arguments when they were trying to bring in the no smoking ban, we used to actually say as mental health nurses, but it's a tool, it's a therapeutic tool that we used to have as a discussion. Now, when I think about it, I'm going, what? But that was the thinking. And I have to say, thankfully, I think we have moved on a little bit from there, because, the public health messages are managing to get through, both for health professionals and for the public. But, I think for me, there is an issue of stigma, certainly, but I also think that, often people don't know how to ask the questions. And going back to that issue again, Nicky, it's people think it's, we talk about drugs being good or bad, or we talk about drugs being hard or soft, or some are okay because they're legitimate and the government...
Or taxed, basically.
Taxed. And so if the government taxes them, it's causing it, so what's the problem? So it's really interesting how we compartmentalize a little bit to either support our use or not. And I think that, for me, helpful, if it's a tip for others, particularly if you're in the health game, not to get into that kind of debate with people about good or bad, strong or soft, legal or illegal. And often a very good opening kind of stance is to talk with people about and say to them, what is your relationship with a blank? So whether that's alcohol, cannabis, whatever the substance is. So what is your relationship with that substance? Because if you focus in, because to be fair, I genuinely believe people have relationships with their drugs. You often say to people, what's your favorite drug? What's your primary drug? People, have almost kind of got a little bit like, that thinking when they're using, it provides me with this, or it gives me this, or whatever. So it's not just that it's a clean cut like taking a paracetamol. We know it's not. It's a bigger issue than that.
It's an emotional issue, isn't it?
It's an absolute emotional attachment. So if you say to people, what's your relationship with this substance? It removes the good, bad, the legal, illegal, the soft, hard, blah, blah, blah. And what I can say, and I genuinely say this even when I'm training with people, and you might have picked up from my accent, I'm Irish. So people might stereotypically say, oh, well, she's Irish, probably likes a good old jar, a good drink. Actually, I have a good relationship with alcohol in that I can actually take it or leave it. I don't get too upset if somebody cancels a pub, sort of outing. Or if I've got no alcohol in the house, I don't go into sort of like major meltdown and run out the first thing in the morning to make sure I've filled up. But I have, and I know, and that's why I stopped smoking, have an appalling relationship with tobacco. If I started to smoke, I would be on 20 a day injecting it in my neck. I loved it. So it's about choices around your relationship. And I know people who take heroin, for instance, on their birthday and at Christmas. Well, so what? That's fine. It works for them. If you can make your drugs work for you, I'm not a policewoman. I'm a health professional. I'm into, is it a good relationship for you, or is it causing problems? If it's not, fantastic. Keep doing it. You know what I mean? But I think if you can say to people...
I was not expecting that health advice from you today, Professor Clancy, so thank you for that.
I suppose what I'm saying is that, and then, of course, it's a problem from whose lens, because, you might think it's not a problem, but your family certainly do, or your children certainly do. But what I mean by that is that starting at the point of asking people, what is your relationship, takes away a lot of those stigmatizing kind of questions that you end up going into in kind of questionnaires. Is it a good drug, bad drug? Is it legal? Is it legal?
Because that's all irrelevant, isn't it? At the end of the day, we're here to help people live the best way they can.
Correct. Making positive choices that work for them in their life. Yeah.
And for me, Nicky, the the introduction to talking about drugs and alcohol is actually quite natural. When we come into work in the morning, we'll often chat about how was your night, what I went out for a meal, etc. It can be that conversational introduction into delving into people's social lives, because you can't look at a patient or a service user just purely using the medical model or their illness. Lots of things do contribute to this, and Carmel's right. It can be family, it could be stress, it could be any of these things. And I think sometimes nursing's almost become a tick box exercise with regards to going through paperwork and ticking things off. The communications have seemed to have gone. The human side of nursing seems to have disappeared. So, yeah, a relationship with a drug, a relationship with a behaviour is often a nice way of introducing this whole concept. And when you're looking, and when you're trying to scale this to see whether people have improved or got worse, again, using that as your tool as opposed to how much do they use, etc. Because people don't count how much they smoke or how much they drank. It's often what else has gone on. I don't know. I slept better last night. That's something that's tangible and it's rewarding. Or I'm really annoyed with what's happened this weekend. I ended up losing all my money when I normally wouldn't have done that. Again, it's another way of introducing the topic without stigmatizing it, and also putting a link to behaviour and consequence, or behaviour and positive outcomes.
I think we're going to go to Vanessa now, because I think we've got a backlog of questions built up there. So sorry, Vanessa, we're back.
Yeah, we've got lots of questions, so I'll
get ready, guys. Brace yourselves.
I'll do a couple, and then you can come back to me as well if you like. So I'm going to start by a question that we got from a paramedic.
I think you've frozen there. Do you want me to have a look and see what we've got in terms of questions?
Can you hear me? Or,
yeah,
go on.
I can hear you.
Am I back in the room? Sorry, I think it's my signal. So we've got a question from a paramedic, which is great comments. Awareness training will give the staff the confidence to ask questions, and due to shortages, this needs to be expanded across the health sector, both pre and in hospital. So it's actually not a question, it's more a comment.
Yeah.
Any thoughts on that?
I mean, absolutely. It's all about awareness raising, and absolutely at the moment with staff so in the trenches, just trying to pull people out of the water. They've no time to, as I say, go upriver to see who the hell has thrown them in. So that is exhausting. So there is something about how do you access some really useful resources, maybe, sort of when you have a little bit of downtime at home that's online. I did send through a couple of professional networks, Vanessa, to you, which I think you're going to be tweeting. If you're have you sent those? You have. Thank you.
I've put them on Facebook and Twitter. For
thank you, Vanessa. Because for the paramedic, you might want to check out an organisation called ISUP, ISSUP.net, and that's the International Society for Substance Use Professionals. So it's kind of more generic as opposed to the nursing one, which I'm a part of, or ISAP, which is actually the doctor's one. But the ISAP one has a fantastic website of huge resources, multiple resources, videos, TED Talks, all sorts of links done by theme. Really recommend checking it out, and even it's free to register with them. So if you want to become a member and be part of their newsletter and so forth, it's a good way of just keeping you tapped into current things that are happening both globally but also within the UK.
Yeah, that's great. Thank you. So we've also got a question that's kind of linked to that. So I'll come to that next. And this has been actually a theme on previous sessions. And that's about what can we do as professionals and educators to promote the teaching of drug and alcohol issues in health and social care curriculum. So that has been a recurring question, actually, for a few of our sessions.
Oh, well, I did give another link to a paper article that I wrote called Getting It Into the Water Supply. And I use that because it's, if you look back in the 1950s, when we had huge tooth decay, which is a major public concern. And really, they didn't know what to do until they introduced fluoride into actual just your drinking water. Hey, presto, tooth decay pretty much eradicated. So I've used that metaphor really as a way of saying that we cannot ignore this anymore. It is the other pandemic in the room, that nobody really has given the same attention to. And in actual fact, if you're looking at the numbers that I quoted at the beginning, you can see it's killing more people. So why this is not getting the same as COVID, I'm not in any way disrespecting the attention COVID is getting, but certainly it's up there with it. And we really do need to think about how we get this into our education. It has to be not even at the point of pre-qualifying courses like nursing, paramedics, et cetera, et cetera. It needs to be in the primary school. How are we actually introducing education around this right through the different educational foray? And then actually within the professional organizations, just if you look at, and this is what's quite horrifying for me, if you look at historically how many hours nurses, for instance, were getting in their undergraduate training, give or take 20 years ago, it was about 3 hours over a 3-year period. Okay. That was 20 years ago. And it's pretty similar in the US as it is in the UK. Now, currently, it's on average 6 hours. That's a 3-hour difference in 20 years. Look at the exponential increase in the ubiquitous side of drug and alcohol use. I mean, it just doesn't map. AMCD years ago, the Advisory Council on the Misuse of Drugs, brought out a very, very nice paper, but it's now so dated, about the need for education. Everybody keeps talking about education and how important it is. Doesn't seem to follow through. Now, some of that is because we don't have the champions. We don't have the champions within, to be fair, within take nursing example. We don't have the addiction specialists who are teaching in the academic group. So the academics who are, and this is one of the things that we keep saying, why hasn't that dial changed in the 20 years? My own hypothesis is because the teachers have not had the training either. So it's kind of perpetuating itself. We don't train the nurses who are in school now. They then go on to become the academics of the future. They didn't have the training either. They don't train it. Nobody kind of gets it. So it's kind of a cyclical thing. We need to break down. We need to start teaching the teachers and then get them to not stop trying to teach the students. First, teach the teachers and get their attitudes right, get their training, give them all the awareness training, give them the tools, the skills, all of the PowerPoints, everything done beautifully, show them how to insert it. And then we can then say something is going to happen, because we don't have all the champions we need at the moment.
Yeah, it's interesting as well, because a lot of addiction services are no longer under NHS contracts either, are they? So I guess that's got a big bearing on it in terms of the workforce going to work in the NHS.
Correct.
And certainly if I was to talk to somebody with expertise on addictions, I would say 9 times out of 10, I would go to somebody in the third sector, because I would know that they're living and breathe addictions work every day rather than NHS nurses.
Well, I sat on, the Orange Guidelines, Sir Professor John Strang, which is looking at treatment, obviously, for opiates. And I was sitting on the review of that, and he asked, what's the single most different thing that's changed since the last guidelines? And quite a number of us, including Mike Flanagan, who is actually a nurse specialist as well, but he's actually, I think, the chair of the non-prescribing forum, the National Non-Prescribing Forum. And we both said the workforce, the biggest change has been the workforce and how it's shifted from statutory to non-statutory. Now, I have no problem with that. There's room for everybody, and that's important. But the fact of the matter is that the minute you moved a lot of the addictions into the non-stat, the dedicated roles of doctors, nurses, people who are attached to traditional NHS type services, they actually got pushed out that role. And now you're finding, so if you're a student nurse and you want to be aligned and have a mentor or go to an addiction service for placement, you may not be able to work and have a mentor who's an addiction nurse. So then where is the next workforce then? Because we're starting to see addiction nurses disappear in terms of formal role. They're still there, but maybe not called that anymore, because in the non-stat, they might be called a generic drug worker, not a nurse. So where is the nurses to actually supervise and support the next generation? They're not there in the clinical areas now either, or at least they're starting to disappear. And the docs will say the same thing to you.
Yeah.
I think from my point of view, Vanessa, it's really odd one, because I'm not pro privatising the NHS in any way, but little bits have been taken away, and we know that. So the third sector have come in. We know how big alcohol and drug related health and impact that is going on in society. We know that. So the third sector have come in, and Carmel's right. Nowadays, I think there's only about 2 or 3 addiction psychiatrist training posts in the UK. So the specialist has gone from the top. And then the nurses like myself have been pushed into a prescribing role. Well, I don't mind prescribing, but so who's doing the therapeutic stuff? It'll be someone with an MVQ, and I'm not patronising MVQ, but the value of a nurse or a doctor is more than the wage you give them.
Yeah.
I actually got thrown out of a seminar, which wouldn't surprise Nicky, where I actually questioned the commissioner, saying, you're obsessed with value for money. And for you, value for money is cost. For me, value for money is getting the most I can from my workforce. Yeah. And that would mean having people with skills and multiple skills that can do one job. And he goes, but what does that mean? I said, well, a nurse isn't just a nurse. A nurse doesn't just give prescriptions. A nurse can do a holistic assessment.
Yeah,
a nurse can see something and go, oh, I wonder if your blood pressure is high. Do the blood pressure and then link it to, oh, you haven't taken your medication this morning. I'll tell you what, come and see me again tomorrow, take your medication, and they can do some health checks as well, as opposed to an MVQ checklist where it is, oh, did the blood pressure was high, refer straight to the doctor. And for me, that's one of the biggest problems, that the specialist nurse or the specialist person in addictions isn't being taught in the right way. It's being taught very linear. And I'm not bragging, and I shouldn't be bragging. I got a phone call less than a month ago from a friend who was working in the NHS saying, I need some advice, but I'm not working in the NHS anymore. I can't find anyone in this hospital that I trust enough for this information. So 5 years down the line, I've left the NHS and I'm getting phone calls from consultants for advice, which tells me something's not right within the health service. If you can't make a referral or get advice from someone within the hospital, something's not quite right. And again, for me, it must be how things are commissioned.
Yeah.
It goes back to Carmel, and I've read Carmel's paper and I've actually presented on it as well, about workforce. We're working in silos. That's the problem. We're working in silos, we're taught in silos, we're funded in silos. We've now become practitioners that work with an exclusion criteria as opposed to an inclusion criteria.
Yeah.
Where else in the NHS would you be too unwell to come to my service, or you're not well enough?
Yeah.
Where else could you be in the NHS where you don't warrant an assessment? But this is the language we're seeing now in new commission services. Yeah. Where else would you have an 18-month waiting list for a therapy? It wouldn't happen. It's really bad how these kinds of things have now become commonplace. But apparently things are getting better. I think from a service user point of view, I think there's more options, but getting in through the front door is still a problem.
Yeah.
Or getting a degree of expertise is still so much of a problem. There used to be this dual diagnosis worker that every CMHT was meant to have. Who is this person? I don't think anyone has actually got one anymore, because it was often seen as a luxury post. But we know that, and Nicky and I talk about this all the time, that this crossover individual has probably got really high complex needs, not just mental health, not just addiction, but physical health. Yeah. And that person who is meant to key work and to be the advocate for this individual is no longer there. It's seen as a post that's removed to put somewhere else. So for me, that's really difficult to work with and understand how silos are still there. We're trying not to teach in silos, but everything else seems to be done that way.
I think it's interesting just to pick up on Adrian's point, but also maybe for those who are watching and listening. There has been, in fairness, a recognition that the workforce has shifted and changed. And this is not a comment about which is better or worse. I would say, actually, this problem is so big, we need everybody's input, okay? Wherever you're starting from, whether that's from a lived experience, peer support level, right through to consultant psychiatrists, etc. Everybody, please come forward, step forward. Nobody will be pushing you away if you think you have something to offer here, because we have such a need. But there are, still clear issues about if you are going to make sure that there's a sustainable workforce that is trained and capable, you do need to make sure that these roles are not compromised and that they're not lost. And there's a fear that if you have a more generic role, then if it's everybody's business, it's kind of nobody's business. There is actually still value, and I hope people would agree with me, of a multidisciplinary approach. Each discipline brings something new from their perspective, from their particular lens. And so I absolutely would say, I would want a psychiatrist at the table, or a GP, a social worker, psychologist, a peer support worker, somebody with lived experience, paramedic, nurse. All of these people, will give a rich account and understanding, and hopefully be able to help that individual in the middle who needs all of that support. And to be fair, Public Health England some time back started to recognize that, people were saying, what are the roles of some of these so-called, sort of traditional people, psychologists, docs, nurses. And so I've just sent through to Vanessa a link that she could send out, which is one that is linked to a series on the different disciplines and their role in drug and alcohol. So the one I've sent through is for nurses and their role in drug and alcohol treatment. But there is a series of those, one, I think, for social work, one for psychology, and one for doctors. And they're all on that kind of public health link. And I would direct anybody, if you're not sure what that role is and what they're doing, and then get involved to see what exactly is happening, that might be a good starting position. But certainly multidisciplinary, multi-professional, multi-agency, we need everybody.
Brilliant.
Well trained.
We've got 10 minutes left, guys, and quite a few questions to get through. So I'm going to hand over to Vanessa for a quick fire round, because I don't want to, we've got so much expertise in the room. We want to get as much out of you guys as possible for the people who are watching. So
bear with me. Some of them, I think,
short answers.
I think we've answered already in what we've just said. There's a question about stigma, whether it's stigma that leads to a failure by doctors and nurses to ask about substance use. That was certainly something I was thinking about as well when we were talking about the inequalities earlier. Any thoughts about stigma and how that might impact on doctors and nurses asking about substance use?
Yeah, I think we have to, I would say that, doctors and nurses are part of the general public. We are just as much exposed to all of the, forgive my French, the crap that media often put out about, be careful, drug addicts, all they do is try and, kill you, rob you, get your money. There's such negative press out there, that unfortunate people with problematic substance use have to wade through all of that rubbish before they often can break through to get to somebody to listen to them and actually appreciate that actually they really do need some support and assistance. So nurses and doctors are just as much exposed to that. Equally, remember, we all have somebody within our circle who has been affected by substance use, so there will be doctors and nurses, social workers who've grown up with people with alcohol problems in their family. They will have experienced perhaps trauma, childhood abuse themselves as a result of addiction, perhaps. So don't forget, doctors and nurses, the social workers, they're human. They're going to bring all of that experience, sadly, to some of their clinical input, and that will color potentially the patient that's in front of them, that reminds them in terms of a counter-transference of their mom, their dad, their sister, or somebody who's caused them pain. So we have to be sympathetic also, because if we're too sort of unsympathetic to our colleagues, they'll shut down and they won't talk about it. So let everybody tell us what they're thinking, work with attitudes, and let's be just genuine and kind to everybody, those with the poorer attitudes and those with the good attitudes. And then we might have a solution.
Yeah. It's brilliant. Next one is, do you think there are cultural differences to drug and alcohol use and the acceptance of this in our society? So cultural differences.
Yeah,
there is big cultural difference. I'll come from a slightly different view, because I know Carmel's already done the Irish point of view. In the Indian culture, beer isn't seen as an alcoholic drink, it's just seen as a drink. So to prove my power, my strength, spirits are what I use. And it's not just the spirit. If I was to invite you around my house and to show you, here's a bottle of Bell's, it shows you that I've got some money. But if I was to bring out a single malt and we're drinking single malt, it gives me a bit of kudos. So culture is really odd. It could be, yes, people have got a drinking culture, but it can also be a status symbol. And from the Indian point of view, it is a very big problem. I remember working in A&E and asking certain people, do you drink alcohol? No. When you speak to the family, he drinks 10 pints a day, but the gentleman hasn't seen the link between the two, or the word isn't right. So it's really odd from that point of view. But yeah, I think it's not just culture. If you look at different parts of the UK, different parts of the UK have got a different relationship with alcohol as well. I know we've got London, and we've got the bars in London, we've got the pubs in the countryside, we've got different relationships wherever we go. And I think it's important that we acknowledge that, because the reason why people drink or socialise are different, but no one actually wakes up or has a life choice of saying, I tell you what, I'm going to be dependent on drugs. They've actually done a lot of experimenting and enjoyment to begin with. There's often that crossover point where things go wrong, and a lot of people come back from that point. There is a significant minority that do require help, and I think half the problem is some cultures will hide these individuals. I know many cultures where mom or dad who drinks too much is kept at home, or there are other ones that are completely ostracized and kicked out of society. So society is a big factor.
Yeah, that's a really great answer. Thank you. I don't know what the question is here. It just says champagne always associated with winners from Grand Prix.
Well, that's looking at kudos, that's looking at prestige, like you were saying, isn't it? The fact that it's an emotional experience. I can see a new name here saying from Dibbit Taylor saying, do you think potential for compassion fatigue in terms of a revolving door nature of addiction? So what do we do about the fact that, everyone thinks that you give treatment, someone gets well and they go and that's job done, and that's not necessarily what happens?
No, my always response is, what do you say to diabetic nurses then? Do they get compassion fatigue? What about other chronic long-term conditions where patients who really shouldn't eat that, or they've just had a heart transplant and now they're back on the full fat? Do we get compassion fatigue for them? Probably, maybe a little bit. Do we get irritated? But I don't know if we necessarily slam them in the way that we do with the first time a drug addict tries to stop taking drugs and we say, you see, they fail. They always fail. So I just think we have to catch ourselves. And
That's a really good point.
I think we have to say, why would we put measures against people who are working in the drug and alcohol field any differently to any other long-term chronic condition, and say to them, why are your patients not managing to succeed? Why are your patients not recovering? Well, hey, hang on. What does that mean? And what does recovery mean, actually? What is success? Is it actually to be drug-free? No, because actually you'll find some patients will come to you and say, you know what, I'm happy to give up the heroin, but I never stop in the cannabis. Well, okay. Let's get off the heroin first. Let's go there and then see where we are. That's success. So I think we have to be really, really careful about this compassion fatigue. It's all about, it's about the professional shifting their position and their lens and determining what's right and wrong, and what's success and what's not success. And certainly in my experience, what I think is success is never necessarily what my patient thinks. So let's start with their position.
Yeah, it's about that whole growth mindset as well, isn't it? That not just writing somebody off because at one point in time they've got an addiction and they're never going to overcome it. But it's about believing in someone, isn't it? And seeing that they've always got the capacity to change and develop. And
I tell, I don't know, I know I say this for people who don't necessarily work in this field, but just let me tell you, people who have substance use issues and have had them for a long, long time, they are exhausted themselves. Get our compassion fatigue. They're exhausted. And what they need to hear is that you're actually there for them, non-judgmentally, listening and prepared to accept where they're at. Please, just be kind. Okay, they've had a very tough journey, and often when you listen, actively listen to what has happened and what has gone before and why they made those choices, to be quite honest, I actually am always in awe that they've even survived. So I think just cut them a break and listen. Okay, you might learn something and say, wow, these guys are actually quite courageous sometimes.
I think as well, the front door to the NHS is actually quite a scary place.
Yeah.
And if you have those attitudes at that front door, you often can turn away the wrong person. And I think each and every one of us who've worked in the community, our biggest fear is picking up the newspaper and finding one of your service users somewhere on there. And what you'll often find is they're looking for help. Now, I'm not saying every A&E department should take everyone in and make a hostel, but often making the experience as a health promotion opportunity. Because you're right, Carmel was right. If a diabetic was to come in and their blood sugars were a little bit high, you would do the health promotion information, you would give them positive reward, you would give them goals, etc. For someone who's drinking, a lot of the time, I think there is fatigue, but often you need to look at yourself. Why am I saying that? Because you wouldn't say it to Doris, who's an 80-year-old lady who had one sherry who fell down the stairs. Often we do it for other people. And I think it's a really odd one. People are busy, and I acknowledge that the NHS is busy, but we all signed up to that anyway. So for me, when someone says, oh, I'm too busy for that, I'm not too busy to care for that person there, to ask them how they're doing, do they want a cup of tea? That's how I build that relationship. That's how I build that trust.
Yeah.
So for me, that's really important.
Yeah, it's been a lot what we've talked about tonight about the human side of addictions, hasn't there, really? I think that's, for me, a strong message that's come out tonight, and about being kind as well, and non-judgmental. I mean,
should we take a couple more questions and then...
I'm looking through the questions, and for people who are listening, it's not that we're not answering, but we're running out of time, and when I look through them, I feel like we've covered a lot of this in our discussion tonight. So I'm going to ask a final question, which is from Alfonso, who joins us every week, which is great. And just a really important point about when we talk about addictions, we're talking about drugs and alcohol, but addictions are obviously much wider, like addictions to food, games, sex, and so on. How come we tend to talk less about other types of addiction? Is it because they are less harmful, or is it because stigma is higher?
That's a great question. Well, if you look at just from the sort of the neurobiology and sort of what the reward pathway in the brain, in actual fact, all addictions are pretty much the same. They run along the same reward pathway. So whether you're searching for the next orgasm or whether you're actually looking for a bit of chocolate, it's actually the same buzz. I mean, the neurochemicals are different, are different. The neurons slightly firing different, but that's really what you're doing, is you're setting off your reward pathway. So in actual fact, when you talk to people who are into gambling or into some sort of behavioral side, actually, how you might approach the treatment is very, very similar in terms of the psychosocial engagement. You would actually take very, very similar responses to how you would work with that. So there is no difference in some respects, other than perhaps cultural in terms of availability. Some can be more hidden because you can do it online, whether that's through porn or whether you can engage in really sexual activity that's hidden behind a door. People kind of think that's, not too bad, whatever. Drugs, of course, because people have to go out and buy them and purchase them in a slightly different way, carry perhaps even greater risks around people's liberty. So maybe that's why it gets the attention, because of potentially its more public facing side. I don't know. I mean, I'm kind of thinking it through a little bit on the hoof, but in terms of the behavioral side and how you would respond, actually, it's probably not that different to actually drugs, whatever the drug is, as people say. What's your drug? That could be all sorts of things.
I think that's a really good question that Alfonso's asked, and I'm still thinking about it. A lot of it could be just down to how sexy it is. Sex, drugs, and rock and roll. That statement has not gone. But no one's going to talk about food, etc., etc. So that's one thing. So perhaps there's a lot of... We're going back to status again. Perhaps it's getting all that notoriety because of what's going on in society. You wouldn't I know programs like The Biggest Loser and all these programs are really good and really inspiring, but the amount of people who you would see in the news who've gone to rehab for a pain control issue or for a detox, again, I think it glamorizes it. I'm not saying full glamour, but it mentions it, and it's just saying the same message over and over again.
Yeah.
So I think that's some of it as well. It's just that society is not fair, and the way that we look at things isn't fair. And I think it's one of those things that are hidden, and we wouldn't really generally talk about it.
I think if I can, I mean, one of the things which maybe is a nice way to end, because often we do a them and us, it's quite, we do the other very nicely sometimes. And certainly, over the course of my career, I've probably certainly done that. And I've certainly witnessed that a lot, where people talk about the other, the different, that we're not them, it's them, the patient, whoever. But actually, I think, Alfonso reminds us, that actually behavior is behavior is behavior. We all have something that we would say probably that we're addicted to, whether that's Carnation Street, whether that's actually the bar of chocolate every night, whether that is reaching for the bottle and having the drink because you don't you can sleep. So actually what's really nice, and maybe something for us to all kind of own, is before, as they say, you take the splinter out of somebody else's eye, just check the plank that might be actually in yours and do just a quick kind of check. Am I really, throw the first stone sort of thing? And I think if we can think about that, that might allow us to be a little bit more empathic, a little bit more compassionate. And even though I don't understand your drug of choice, I think maybe we all have a drug of choice, and just check out what it is and try and touch the feeling behind that and be a little bit more understanding, because we all often tend to have some crutch. And so maybe that's what people should be thinking about, actually.
Yeah. Right.
I think we do need to come to an end now. That went so fast. Thank you so much for that. And for all people who've written so many questions on Facebook and on Twitter, we will come to them. And if we couldn't give you an answer in this session, we'll certainly tweet something out as well.
Okay.
Yeah, so we'll come around to everybody to see if anyone's got any final thoughts. Again, I need to find a different way of saying that. It sounds so final, doesn't it? So anything they want to share with the audience before we close for tonight. So I'll come to Adrian. Is there anything that you wanted to highlight before we finish up tonight?
I know Carmel's going to continue what I say, but IntNSA is an organisation that is global, but we do have a UK chapter, and so which I am the president of. But we have we don't really have any representatives yet. So, if any of you would be willing to join a workforce that is willing to start making noise for service users or patients who suffer from alcohol or drugs or any form of addictions, do get in contact with the IntNSA website and find me that way. I know there is a link in the chat, and it's going back to Carmel's original statement of that any nurse can be an addictions nurse. Just asking that question is really, really important. Even to the paramedics who gave some really good questions. Alcohol and drugs are out there everywhere. And I think it's really important that we acknowledge it, that it's not good or bad. People use it for many different reasons. Unfortunately, we only see the two extremes. People having a great time, or people picked up from ditches and corners with vomit all over them, or as Vanessa introduced today, with the worst case. So for me, if you're willing to start making some noise, do come and join IntNSA, or at least show me you're interested, and we can see how much noise we can make, not just in the UK, but I do have colleagues in Europe, Australia, and the rest of the world, which we can start doing some alliances.
Brilliant. Great. Brilliant. Carmel?
Yeah, no, I would never add to Adrian. I think you've said it all, Adrian, which is really good. What I would say to everybody, though, and this is kind of hopefully a take-home message as well, is substance use, and particularly problematic substance use is a lifespan. It can start in utero with a mom who unfortunately is using, so baby can come out and be unfortunately dependent. And it can actually now, and increasingly, and I think this is something that we didn't really touch on in terms of sub-communities and different types of communities who have their own needs, but we are absolutely invisible to our older community. Who are behind doors, who are particularly more isolated because of COVID at the moment. And we didn't touch on the implications of addictions and COVID. But please don't forget, this is a lifespan issue. It is not just about the cool kids hanging out, teenagers, young people. This actually is, sort of 70, 80-year-olds drinking, potentially using, sort of various narcotics to help them sleep or to cope with comorbidity or to cope with bereavement. So, that everybody that comes in your eyesight and your eye line, please remember, ask them, hey, how are you doing? And what drugs are you using today?
Yeah.
Please, with that intonation as well, I liked it.
Absolutely.
So, Vanessa?
Yeah, I started tonight by talking about it being World Suicide Prevention Day, and I think it's been quite interesting that there's been a theme tonight about being human, about connecting with humanity, and about being kind. And I think whether we're talking about reaching out to someone who's suicidal or reaching out to someone who's got an addiction or potentially has got an addiction and is suicidal, because as we've talked about tonight, people aren't symptoms, people are human beings, and often it's just, it's not one problem, it's lots of things. And we've talked about things like the impact of trauma, we've talked about cultural differences and things. So I think my message really is about that. It's about being human, being kind, and about connecting with people and like Carmel says, asking the questions and talking to people like they're the same as you, really, because it could be any of us who've got an addictions problem. And I think, there's too much othering goes on a lot of the time. So yeah, that's my message. And thank you both, because it's been really, really interesting. And I've really appreciated a really straight, honest talking session tonight, hasn't it? Really, thank you.
Yeah, a message from Alan just coming in lately, so talking about the fact that maybe one of the reasons people don't ask is they're not quite sure what to do. If that's the case, there's nothing worse than asking a question of being unsure. If that's the case, don't forget that Carmel and Adrian have both told us about a free conference that we can use to skill up. That is going to be being tweeted out. You have that information. Please join it. You'll be more than welcome. And another thing to remind you of in terms of free education coming up, it's MHNR. So Mental Health Nursing Research Conference coming up, starts on Tuesday at 7 p.m. Following this same format. The details are in today's show credits, and we would love to see you joining in on that if you get a chance. So just wishing you all a lovely, lovely evening and saying goodbye from us all now. So take care, everybody.
Take care, everybody. Bye-bye. Thank you.
Bye.